Welcome to the American Society of Hematology meeting here in San Francisco, 2014. I'm John Gribben from Barts Cancer Institute. I'm joined by my good friend Andre Goy from Hackensack in New Jersey. And we're here to talk today about mantle cell lymphoma. Always a problem disease that has all the worst characteristics of both being more aggressive and less treatable, but a lot new happening in this era. So what do you view as the kind of major challenges in how you handle your patients with mantle cell lymphoma?
You're right, mantle cell lymphoma, John, is actually a challenging disease and has generated interest both from the physician and the patient community to be more creative. So we have made a lot of progress over the last 2 decades and have clearly improved the survival of mantle cell lymphoma. So the challenge of mantle cell lymphoma is that the disease with standard therapy that becomes chemo-resistant very quickly. So over the years, we have still significantly shown that high-dose therapy upfront, consolidation, or dose-intensive strategy with the cytarabine-containing regimen and rituximab brings into much longer PFS in excess of 5 years, and achieving a CR early in this patient population that can tolerate this therapy translates into better outcome.
Well, you raised that issue about those who can tolerate that therapy. Of course, like so many of the other, I hesitate to use the term indolent lymphoma for mantle cell lymphoma. I don't think it's an appropriate term anymore, but like so many of these other diseases, there are, of course, a large number of patients for whom these very aggressive approaches haven't been ideal.
You're exactly right, because the median age of diagnosis is in the mid to late 60s, so these patients cannot go on high-dose therapy. So there's an unmet need to try to develop novel strategy. So the R-CHOP became the default in that setting, and then the median progression for survival is not very different than that CHOP, as you've shown actually several years ago. And then although it improved the CR rate, it doesn't improve the PFS. So the BR, bendamustine Rituxan, is slightly better in PFS, and it's a bit less toxic in that older population, so it became a backbone to try to build up on this. So there's been a number of strategies, both with R-CHOP and with the BR, to try to build up on this. So R-CHOP bortezomib was just approved by the FDA based on the data presented in ASCO with a 60% improvement of the PFS in a frontline setting. So this is replacing the vincristine by bortezomib versus R-CHOP. So this is only an interesting option, and bendamustine Rituxan also, because it's less toxic in the short term, it has also provided a platform to try to build up on this. So it's being looked at actually at ECOG in combination with bortezomib and other biological agents in terms of maintenance.
Sure. Now, of course, you raised this issue about the emergence of resistance that occurs in this. So it's really exciting news, isn't it, that we have many more drugs that are being studied and are becoming approved for use, not just in clinical trials, but in routine clinical practice for our patients with mantle cell lymphoma.
You're right. In a frontline setting, there's already, as we discussed, a little bit of debate on how to treat this patient. In a relapse setting, there's no good option with standard therapy, even with a high-dose therapy and transplant. And outside the small subset of patients that can undergo a mini allotransplant given the age and have a long-term benefit, there's no great option. So all these novel therapies offer an opportunity, and there's a number of them. Obviously, bortezomib was the first one approved in the US, and then lenalidomide and ibrutinib, and in Europe we have temsirolimus and ibrutinib. So this provides a platform to either build up again with combination chemotherapy, but also more interestingly to start to develop non-chemotherapy option in that setting.